Hello, I'm Dr. Nirujan. This is basically an introductory lecture on ERPM medicine curriculum. Straight away, I'll move on to the lecture. So, this lecture is basically for the freshers who are going to sit the ERPM exam for the first time. So, first of all, what is ERPM? So, no big deal. ERPM stands for Examination to Register to Practice Medicine. And what is it really? So it's basically a screening or barrier exam conducted by the Sri Lanka Medical Council, which is the regulatory body uh, of Sri Lanka health system. Uh, this is conducted for Sri Lankan citizens who have obtained their medical degree from overseas medical schools. So this exam was previously called as Act 16 because the examination is conducted or prescribed in terms of Act number 16 according to the Medical Ordinance of Sri Lanka. But now, however, it's not called Act 16 anymore. It's called ERPM. Clear? So, how do one become eligible to sit for ERPM? Or in other words, what is the requirement for a person to sit for ERPM? First of all, the candidate should be a Sri Lankan citizen and the candidate should possess a medical degree which is from a medical school or faculty which is recognized by the SLMC. The important thing is the medical school should be recognized by SLMC. So once you get through the ERPM exam, then you are eligible to apply for a provisional registration. So from what parts do ERPM students come from? Of course, this pattern varies from time to time. So currently, most of the students come from Russia and the other Soviet Union countries like Belarus, and a good chunk come from Bangladesh still, China, and a few from India, Nepal, etc. Few years back, a huge amount of students used to come from Bangladesh, but unfortunately, from, if I'm not wrong, from 2014 onwards, a particular university in Bangladesh has been cancelled of its recognition by SLMC, so that the influx of Bangladeshi students have gone down drastically. So you might have a question now. Well, these students have a medical degree from a medical school which is recognized by SLMC. So why is there a need to conduct an exam? Why would we burden them additionally? Why can't they practice medicine straight away in Sri Lanka? Of course, the core medical aspects or the core medicine is similar wherever you graduate, wherever you practice. There's no doubt about it. No doubt about it. So, I mean, myocardial infarction, the management, the pathophysiology are more or less the same, whether you practice in America, China, Russia, Bangladesh, or Sri Lanka. But there are subtle differences in certain aspects. When you take medicine, especially the epidemiology of infectious disease. For example, if you take dengue, dengue is more prevalent in Sri Lanka, it's more severe, whereas in Thailand or Singapore, dengue is less prevalent or less virulent, to be honest. And you see leptos, typhus, and melioid fairly commonly in Sri Lanka, but in some other parts of the world, you might see Lyme and melioid very commonly. Sorry, Lyme and brucella commonly. So you need to know about the epidemiology, the community of diseases in Sri Lanka, not only the communicable, the infectious diseases, but other non-communicable diseases like cystic fibrosis is very common in the western part of the world, but you hardly see cystic fibrosis patients here. So the pattern varies. So the basic idea is to check whether the candidate is aware about the local pattern of diseases, the common diseases, so that I mean the person who is going to be a house officer would be well familiar with that pattern. And the medical legal system is also different, and the community medicine, the community healthcare is different to other countries, so that those are also checked. So then the scope of this exam is mainly to select a house officer or intern medical officer. This is where people go wrong. It's basically a house officer interview. This exam is basically like a house officer interview. So say that you have to display skills for that particular job only. So the particular duty of the house officer is to basically, the officer should have the ability to take history, examine him, and to make a form or formulate a basic plan. Anyway, these house officers would be supervised by either the registrars or senior house officers, SHOs. So this exam won't be expecting hi-fi knowledge. The extensive pathophysiology of multiple sclerosis, neuromyelitis optica spectrum disorders, and how do they present. No, those things are very high-fi. Those are for postgraduate candidates. So that is where people go wrong. You need to study for the exam. You need to target what is exactly required. Okay. So you should be very fluent in the fundamental skills and basic theory so that you easily get through the exam. This is no different to the other screening or barrier exams in other countries. For example, AMC in Australia, PLAB in UK, and USMLE in US. So it's similar to the other exams. So the scope of the exam, I mentioned earlier as well. So it's basically to check the core knowledge of common communicable and non-communicable diseases and their prevention. It's mainly dealt in community medicine. And to check whether the candidate has the ability to make a provisional diagnosis and initial plan of management. You don't need to put a hi-fi plan. You have to make sure that the patient would be stable and there should be an initial plan. So the candidate should be displaying that he is a safe guy who can uh, tackle the patient until a senior opinion is taken. And it also checks the ability to adapt to the facilities and resources available in the hospital. So you might know when the ERPM students are ranked, they are ranked below the state students according to the merit order. So mostly they are ranked, they are posted in peripheral hospitals. So in the hospital you work, you might not have widely available facilities like MRI. So when you are working in a hospital and you get a stroke patient, for example, you might not even have a NCCT brain. So you should know how the protocol, how to transfer the patient, how to get it done. So the basic ideas. And the patient should, the candidate should have the ability to adapt to the facilities and resources available in the hospital. Okay? And also the candidate should have a basic knowledge of the healthcare structure and the medical legal system in Sri Lanka. So that is separately checked in forensics exam. So then we'll move on to the structure of ERPM. The ERPM has 4 parts. Okay. A, B, C, and D. So the medicine would have 3 parts. Anyway, I'll tell about it later as well. So part A has basically 2 main tracks and a subtract. So medicine tract contains 2 papers, pediatric and medicine paper. And surgical tract has general surgery and genome. And there would be a separate psychiatry tract. So if you move on to the medical tract, which I'm going to concentrate today, medicine have 25 true or false MCQs and 25 best choice MCQs. The paper is, the duration of the paper is 2.5 hours. Okay. So the total marks which the paper carries is 250. And fortunately, the cutoff to pass this exam is 45%. That is 112.5 mark. That is more than enough. So imagine now, when you go in the community, what do the patients expect? They expect a doctor to have 100%. For example, you can't go to a patient and say that, I'm sorry, I learned about myocardial infarction, but I didn't learn about migraine. So please let me learn it in about a couple of days and come and treat you. No. So they expect 100% from you. But here, fortunately, in the exam, it's only 45% which is required. So of your knowledge. So it's honestly not very difficult to pass if you understand the basics and the structure of the exam and certain tricks how to get through, because passing exam is not only related to the knowledge, but also related to the techniques, how to approach the exam. Okay. So true, false, most of you must be aware that each stem would have 5 responses. Some of them would be correct, some of them would be false. And for example, each correct response would carry 1 positive marks, and each false response would be carrying a negative mark. So, for example, if you get 3 correct responses and 2 wrong responses, +3 and -2, you might only get only 1 mark for that question. On the other hand, if you get 3 false or wrong responses and 2 correct responses, ultimately your marks is going to be 0. The fortunate thing is negative marks will not be carried over. So the maximum mark or minimum mark you can get for a question is 0, and the maximum mark is 5. Okay. So why is it important? Because it's very important when you mark these true false type questions, because if you are sure that you are sure about 3 or 4 stems, then it is always advisable not to mark the 5th stem, the doubt one. Because now say that you are very confident about 4 stems, and you are not very sure about the 5th stem. It's always okay to leave the 5th stem. So you get about 4 stems correct. You're going to get them for sure. But if you mark that 5th stem, and if it goes wrong, then you're going to get 3 marks only, rather than 4 marks. So that is basically a mistake sometimes candidate makes. They tend to mark everything, and you are free to leave without marking. You won't be penalized. If you don't mark, you won't get a mark. And the rest of the 25 would be SBA, single best answers. Each question would have 5 responses. Out of those 5, only 1 would be correct. So it's basically easy. If you know your theory well or the basics well, it's easy to score marks in this, because true false would come from a wide variety of theory. Sometimes it might be difficult for even an advanced rebel trainer to mark everything correct. So the easiest way to score is to score in the SBA. This is proven in the studies previously conducted among undergraduate curriculums as well, even among the local curriculum. So out of 25 SBAs, I would say that you better target to get 12 to 15 correct. So it's easy that you can ensure a majority of chunk of marks can be obtained from SBAs. Okay. So you can put less effort and easily pass if you can do that approach. We'll be talking about the tips and tricks of MCQ papers in medicine later when we do the papers, but it is just to give you an overview. And the paper, as I mentioned earlier, would last for 2.5 hours, and 45% is the pass mark. And we spoke about part A, and part B is the clinical component. When you take medicine, there are 2 short cases and a long case, which is observed history taking, a medical consultation. For you to sit for the exam, you should clear the medical tract in part A. Okay, then only you will be permitted to sit for the part B exam. So what is there in part B? You have a station 1 called medical consultation, that is basically observed history taking, where you would be given a patient and there will be 2 examiners. The patient would come up with a presenting complaint, like, so for example, one of the common cases given is chest pain. So sometimes dizziness, syncopal episodes, so those are also given. So you should be able to get the history. So the important part here is you have 20 minutes. So here you should be able to demonstrate your language skills, your core knowledge, communication skills. And the important thing is you should be covering all the components of histories. The mistake candidate makes usually is they tend to give a huge value to the history of presenting complaint, and then at the end of the day, they forget to cover the components. Unfortunately, the ERPM marking scheme doesn't have different weightage to date. Until this time, up to now, there is no weightage marking scheme. That is basically a column tick marking scheme, so that if you have covered the topic, you will get the marks. So even history of presenting complaint, which you take for a long time, carries equal marks for as if for allergy, past surgical, past medical, and everything. So what I would suggest is you make sure that you cover everything. But having said that, you'll have to give value to the history of presenting complaint, because at the end of the consultation, you have to come up with your differentials, a problem list, summary, and you will have to discuss about the initial management as well. For that, you need some amount of history presenting complaint, but don't forget to complete the other components, because unfortunately you will lose marks. Okay, we'll talk about that medical consultation tract when we do the clinical components later. And I'll move on to this station 2, which has two separate stations. Those are short cases, two separate short cases lasting for 10 minutes, 6 plus 4, 6 for examination and 4 to discuss. Out of the two cases, usual pattern is to give one short case where you need to use your step, and one short case where you don't need the use of step. For example, you would get either one case from CVS or RS and either one case from abdomen or neuro. Okay. And that also some people do say that they try to give one case below the abdomen and one case above the abdomen. These are just arbitrary, but usually it's the pattern where the cases are given. So I mean, say if you get CVS and then you would get abdomen, you never get abdomen and lower limb together, usually. So that is the pattern so far being followed. So the core skills checked here are history taking, physical examination, identification of abnormal signs, differential diagnosis, formulating differential diagnosis, formulating a problem list and identifying the problems, patient management, and communication skills. So there will be two independent examiners in clinical components, part B, for medical consultation and short cases. Each would mark you individually. Say that if one has given you 60 and the other has given you 50, the final mark is going to be 55. Okay. So the minimum pass mark for each component is going to be 50. Okay. So again, to reiterate, what is in the medical curriculum? So medical tract has a part A, which is paper 1, consisting of 25 SBS and 25 MCQ, which we spoke about earlier, and 45% is a cutoff. And part B, it has two sets of short cases and an observed risk taking session. I told about the short case setting and observed risk taking setting. And there are common short cases and common topics to observe risk taking. And I mean, it's easy when you are familiar with those topics and the common short cases, so that you can tackle them easily. So mostly people do come down in the part B when you take the ERPM history. That's partly because people are not familiar with the examination techniques which are expected here and the commonality of the topics which are given for obstructive taking. So once you know the topics, it's easy to pass. And then the part C is emergency viva. So the part C is basically emergency viva. So this emergency viva in the medical tract has two components, emergency medicine and emergency pediatrics. The unfortunate thing here is, to pass this part C, you will have to get through both. I mean, to pass that medical tract, part C, you'll have to get through both emergency medicine and emergency pediatrics. So what happens if you fail one? You'll have to sit for both again the next time. So that is the only problem. Okay. But if you fail in surgery, that's perfectly okay. You can clear the medical tract emergencies. And part D is going to be the community medicine and forensics, which the other teachers would talk to you. So what are the myths? I mean, there are several myths. I mean, these are some of the myths I came across about ERPM. The exam is difficult to pass or the theory load is high. It's utterly wrong. You all have graduated from a reputed faculty. So, I mean, the theory load, I mean, it's slightly high, but I mean, it's not humongous as people do imagine. So what they expect is a theory which is adequate to produce a safe intern. That is what is expected. As I mentioned earlier, no one would question about a rare disease like autoimmune encephalitis and its management, the pathophysiology of that. No, no one would ask about neuromyelitis spectrum disorders, nothing. They would ask about basic questions mostly. Most of the questions are easy. And for 45 marks, of course, it's very easy to get that 45% of marks. And the knowledge of the ERPM candidates are suboptimal. There is a variation in the knowledge depending on the faculty, but usually it's wrong. I mean, it's not a knowledge which is suboptimal. It's the difference of the epidemiology of the disease and the community of cases we encounter in Sri Lanka, which is different to the universities or the setting where the candidates come from. So it's not basically the knowledge. So the knowledge you have on MI is the same, which is expected in Sri Lanka. But the community of cases might differ. Say that a person coming from Belarus might not be very familiar with leptospirosis or dengue. The pattern there would differ from what is there in Sri Lanka. So that candidate should emphasize more on learning these things. So that is the difference. It's not the core knowledge. It's basically the community. And some people do think that I'll clear tracks one by one. No, you can't clear all tracks in one go, because now it's an exam. Now you have spent millions of dollars and you go for classes. Why should you waste your time? Time is money. Say that if some people do sit, I'll sit for the medical tract in one go, surgical tract in one go, then the other tracks in the other go. You don't need to do like that. The exams are so easy. If you target and if you study properly, target your papers, and if you target the exam, if you identify how you are being marked or assessed, then it's easy to pass and clear everything in one track. So you will come up in the merit, so you can go to a better station. What will happen if you clear tracks in 2 or 3 sittings? Then you will be put down in the merit. You will be posted to a peripheral station where the facilities are poor. You will be in a psychological stress. You won't have the liberty to choose station. So that is very disadvantageous. So you can clear tracks in all go. So just to wrap up, what happens once you get through the exam? You have to apply for the completion certificate. And once you apply and once you get that certificate, then you are eligible to apply for provisional registration, or you may be fit to apply for the internship. And yeah, you will be given or posted to an intern station according to your merit. Okay, that's all for the introductory lecture on medical curriculum. The other teachers would do their respective streams as well. And we'll be having an elaborate session on how to tackle the problems in MCQs, how to tackle the Vivas, how to tackle the short cases and observatory taking in detail in the separate lectures. And we'll be doing a module system for the medicine theory curriculum, and we'll be doing online as well as physical classes for the clinical cases. And thank you for being awake and not sleeping. Yeah. It's important that you dream, but don't daydream. Dream for a good hope, good future. Okay, thank you. Bye.